Welcome to Topics Explained, the M3 Clerkship series. This is the quick review of bilirubin and jaundice, the essential pathway and differential in under 8 minutes. If you want the deep dive covering inherited syndromes, neonatal jaundice, and the full 4-step hepatic processing system, check out our full-length version. But if you need the core framework fast for rounds, for a shelf exam, for a clinical vignette, this is the one. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Here's the whole bilirubin story in one picture. Old red blood cells are consumed by macrophages in the spleen and liver. Heme is broken down to biliverdin and then to unconjugated bilirubin. Unconjugated bilirubin is water insoluble, so it rides albumin through the blood to the liver. The liver conjugates it using the enzyme UGT1A1, making it water-soluble. Conjugated bilirubin is then excreted into bile, flows into the small intestine, and gut bacteria convert it to urobilinogen. Most urobilinogen leaves in the stool as urobilines, that's the brown color. A small fraction gets reabsorbed and filtered by the kidneys, making urine yellow. Two board pearls to lock in right now. Unconjugated bilirubin is albumin-bound and can never appear in urine, while conjugated bilirubin is water-soluble and can. That single fact drives most of the lab findings in jaundice. Prehepatic jaundice is all about overproduction. Hemolytic anemias, sickle cell spherocytosis, G6PD, autoimmune, destroy red cells faster than the liver can conjugate the bilirubin, so unconjugated bilirubin rises. The direct fraction stays below 15% of total. Here's what trips students up. Urine is dark in hemolysis, but that's from excess urobilinogen being reabsorbed from the gut and filtered by the kidneys, not from bilirubin itself. The urine dipstick for bilirubin is actually negative. Stool is normal or dark. LFTs are normal. Hemolysis alone rarely pushes bilirubin above 4 mg per deciliter, so if you see 15 in a hemolytic patient, think concurrent liver disease. The classic complication of chronic hemolysis is pigmented calcium bilirubinate gallstones. This category also includes Gilbert syndrome, the most common inherited hyperbilirubinemia at 3 to 7% prevalence, mild unconjugated elevations that only surface during fasting or stress, completely benign. If you're finding this helpful, hit the like button and subscribe so you don't miss future quick reviews. Hepatic jaundice comes in 2 patterns: hepatocellular injury, viral hepatitis, drug toxicity, alcoholic hepatitis, damages both the hepatocytes and the small bile ductules. You lose conjugation and excretion at the same time, so both fractions of bilirubin rise. The signature is markedly elevated AST and ALT. Viral and toxin-mediated injury pushes ALT into the hundreds or thousands, while alcoholic hepatitis classically shows an AST to ALT ratio of at least 2 to 1 with AST rarely exceeding 300. Urine is dark from conjugated bilirubin leaking into the blood and getting filtered, but urobilinogen is normal or decreased because less bilirubin is reaching the gut. The second pattern is intrahepatic cholestasis, where bile flow is impaired within the liver. The lab hallmark is elevated alkaline phosphatase and GGT out of proportion to transaminases. Think PBC, PSC, drugs, cholestasis of pregnancy. The key distinction: ultrasound shows no dilated bile ducts. That's what separates intrahepatic from extrahepatic cholestasis. In posthepatic jaundice, something is physically blocking the bile duct. Choledochlothiasis is the most common cause. Pancreatic head carcinoma causes the classic painless jaundice, and if you find a palpable, non-tender gallbladder, that's Courvoisier sign. When bile backs up, conjugated bilirubin spills into the blood and urine, making the urine dark and bilirubin positive on dipstick. Bile salts deposit in skin, causing pruritus. And because no bilirubin reaches the gut, stool goes pale and urobilinogen disappears from the urine. Patients also develop steatorrhea and malabsorption of fat-soluble vitamins A, D, E, and K. The first imaging test: RUQ ultrasound looking for dilated bile ducts. So when you see a jaundice patient, the approach is simple. Step 1. Fractionate the bilirubin. If it's mostly unconjugated, direct less than 15%. Check for hemolysis with reticulocyte count, LDH, haptoglobin, and peripheral smear. If hemolysis is absent and the patient is otherwise healthy with mild elevation, that's Gilbert syndrome and you're done. If the bilirubin is conjugated, determine the injury pattern: hepatocellular with elevated transaminases versus cholestatic with elevated alkaline phosphatase and GGT. For cholestasis, get an ultrasound. Dilated ducts mean extrahepatic obstruction, no dilation means intrahepatic. Quick bedside trick: a urine dipstick positive for bilirubin immediately confirms conjugated hyperbilirubinemia. Here's the high-yield comparison table you need for every jaundice question. Prehepatic, unconjugated bilirubin up, urine bilirubin absent, urobilinogen increased, stool normal, LFTs normal. Hepatic, mixed bilirubin, urine bilirubin present, urobilinogen variable, transaminases markedly elevated. Posthepatic, conjugated bilirubin up, urine bilirubin present, urobilinogen absent, stool pale, ALP and GGT markedly elevated. That's the whole framework. Thanks for watching. If this quick review was helpful, please like, subscribe, and share it with a classmate. For the full deep dive including inherited syndromes, neonatal jaundice, and kernicterus, check out our complete bilirubin metabolism and jaundice video. References for this video include Harrison's Principles of Internal Medicine, 22nd edition, chapters 52 and 349, and recent reviews from Pediatric Research and the American Journal of Physiology. For the full deep dive, check out our comprehensive bilirubin metabolism video.